Hi and welcome to week 7. So this week we will be learning about composite restorations. So what is composite? Composite is a type of dental material that can be used for aesthetic purposes. It is an organic matrix of resin containing inorganic filler particles and pigments that allow it to blend in with natural teeth shapes. It can also be known as a filler or build composite, and it was developed in the 1960s by Dr. Raphael Brown. So amalgam versus composite. There are some vast differences, obviously, just besides the color of it. So amalgam, it does last longer, it does cost less. There are some safety concerns with the amount of mercury that it releases. They can also crack and fracture with temperature changes, and they are held into place in the tooth with mechanical retention, so they are not physically bonded into the teeth. Composite, on the other hand, is known to be more aesthetic. It is not affected by temperature changes. It does require more skill to place successfully, but it can discolor over time. It does not whiten either if you choose to do whitening procedures. Now, it is different from amalgam as well, that it is chemically bonded into the teeth. So it is bonded, whereas amalgam is more so held in there with undercuts placed into the preparation. So what is composite composed of? Composite resins consist of a continuous polymeric or resin matrix in which inorganic filler is dispersed. The organic resin matrix is usually composed of bis-GMA, and then the inorganic fill dispensed throughout the resin matrix usually consists of ceramic materials that can include quartz or silica, lithium, aluminum silicate, barium glasses, or nanofill particles from zirconium. Types of dental composites. So as you can see here, there are about 5 different kinds of different types of dental composites that you may come across. They are based on their size, the amount of particles, and even the makeup of the inorganic fillers that it's composed of. So we have conventional large or macrofill, we have a microfill, a hybrid, microhybrids, and nanofills. So let's get into those a little more in depth. So first we have macrofill or conventional large. The particle size is large compared to the other types, which we will talk more about next, which does not allow it to be polished as smoothly. Those particles are too big in size to get a fine, smooth polish. This can allow more extrinsic staining to discolor the composite, and coffees, teas, smoking, anything that stains can also lead to faster discoloration. Then we have microfilled. They are designed to improve that rough surface characteristics that other types of composites lack, and it also closely resembles tooth enamel. They are less susceptible to recurrent caries, plaque buildup, or extrinsic staining due to this very small particle size. They also, though, may be more susceptible to shearing, but they do display great wear resistance to toothbrush abrasion. And they also have slightly increased water absorption values. And then we have hybrid, which is kind of the best of both worlds here. We have a mixture of small and large particles all in one composite, so it's going to be a strong material and have great wear resistance, but it also is going to polish very nicely as well and give that smooth appearance. Next we have microhybrids. So again, a mix of particle sizes, and they are also very popular because they combine these properties to kind of cherry pick the best characteristics. They make it easier to duplicate natural tooth shades as well because they offer different light opacities to help simulate that color of natural teeth. There are more opaque shades available for those initial layers to reproduce the color of dentin underneath the enamel, and then also less opaque shades to help reproduce that enamel coloring as well. And then we have nanofills. So these are the newest category. They are very similar to microhybrids, and again, they are strong and aesthetic, gives you a nice polish as well. So tooth preparation for composite restoration. Cavity preparations for aesthetic materials should be as conservative as possible. We want to make sure that we're not removing too much tooth structure. If you remember back from amalgams are, the cavity prep is designed with an undercut to hold that amalgam into place. So that means unnecessary tooth structure has to be removed in order to create those undercuts. For composite restorations, we don't need to place those undercuts, so we are saving a little bit more tooth structure while prepping. There are two types of cavity preparations. One is conventional, and then two is modified. So with the conventional one, the cavo surface part of the preparation should end in a right angle between the cut tooth and the uncut tooth. And then for modified, it is similar to conventional, except they do not routinely extend into the dentin. So for preference, we should kind of want to go towards that modified cavity prep. Ultimately, it's not up to us, it's up to the dentist, but you may come across more modified designs these days just to help save on unnecessary tooth removal. So we have dentinal tubules, which are a vital part of our teeth. They're located in the dentin and help us feel sensations in our teeth. So dentinal hypersensitivity is believed to result from movement of the fluid within those dentinal tubules. And during a cavity preparation, debris is forced into these dentinal tubules, which can affect bonding. If they're too filled with the debris, you're not going to get a good bond with that composite to the tooth. So we have this smear layer, which is that layer of debris when we are using a rotary instrument like a handpiece and burr, or even certain hand instruments like files that can create layers of debris. So when we have the smear layer, bonding is ultimately affected. So what do we do to fix that? We etch. That etch is going to help remove that smear layer and open up those dental tubules. So if you are just etching with the plain syringe of 37% phosphoric acid, it is going to remove that entire smear layer. But newer technology, we have universal self-etching systems like the VivaPen adhese system that we are going to be using in lab. That is self-etching. There is etch built into that adhesive, so that kind of works in a different way than normal etch. It is not going to remove the smear layer. It is actually going to incorporate that smear layer into the bonding agent, which helps it bond pretty well to the tooth. So again, regular etch, smear layer is gone. Self-etch, like the VivaPen that we use, it is going to take that smear layer and add, almost like it's going to be the glue that holds that filling to the dentinal tubules. So it's more so incorporating it. Just an FYI. As you can see in this picture here, you see right in the center that dentinal tubule and all of that debris that is shoved down in there. You can also see towards the top, they have that smear layer as well shown. So let's talk a little bit more about etch. Etching demineralizes portions of the hydroxyapatite crystals found in enamel and dentin to create a porous surface that allows the formation of resin tags in the dentin structure. Essentially, an etched surface has pores that allow the resin to permeate and attach to the tooth. It is important to note that enamel and dentin do respond differently to etching. For dentin, etch improves micromechanical retention by removing that smear layer, whereas for the enamel, it's just leaving a roughened surface with kind of peaks and valleys that allow it to adhere better. Enamel is highly inorganic, while dentin is more of a hydrated tissue, so again, they just naturally respond differently. So always read the manufacturer's instructions when using etch, because different companies may have different recommended time frames or methods that you use to etch the teeth. And typically a 32% to 40% phosphoric acid is what's typically used. I know in my previous offices we always used 37% phosphoric acid. Continuing with etch, make sure that you're not rubbing or scrubbing the edge into the surfaces of the tooth, because that can destroy those fragile edges of the pores that are being formed on the surface. So you can take a micro brush and kind of move the edge around to get on all areas, but you should never forcefully scrub or rub it in. You do want to apply to the enamel for 15 seconds and then to the dentin for another 15 seconds for a total of 30 seconds. Now this can change based on preferences or manufacturer's instructions, but that's just a general indicator. Also, after that etch is on there for the allotted amount of time, you do want to make sure you're rinsing thoroughly, at least a good 10 to 20 seconds, and use the high power. You can use some air mixed in with the water as well, just to make sure it's all being removed, because if there is any residue of that phosphoric acid, it's going to affect the filling, and then also that helps to remove that smear layer completely to allow for better bonding. And then it's kind of a common misconception. I thought the same thing until about halfway through my career. I always dried so thoroughly to where it gave that chalky appearance that we want etch to look like. Like I almost over dried it, like bone dry. And I've come to learn that that is actually not what we want. We want to air dry minimally, because a little bit, you don't want it to be visibly wet, but you don't want it to be completely ridden of any moisture. That moisture is going to allow for successful bonding. Loss of water from the dental surface when drying too much will affect how well that bonding agent is going to be accepted into the tooth. So air dry a little bit. You want to get that light chalky frosty appearance, but you definitely don't want it bone dry before you are putting your bonding agent on. So just some etching tips. Primary teeth typically do need to be etched a little bit longer because the enamel rods don't extend to the surface all of the way, and if we only keep it on there for up to 30 seconds, it could leave a very random pattern with how the etch goes into those dental tubules. On the other hand, newly erupted permanent teeth may actually require a shorting etching time. Heavily fluoridated teeth could require longer etching, up to 2 minutes even. Contamination from your saliva means that we have to repeat that etching process. If we repeat the process, say that we did the etching for 30 seconds and the patient goes to swallow, we only need to repeat the etching for about 10 seconds, just enough to clear that saliva debris out of the tubules. Etching too long can actually cause weaker bonding, and then fresh cut enamel etches faster than unprepared enamel. So if a doctor is preparing a filling on a chipped tooth, it's usually better to have them roughen the surface around that chipped tooth for better bonding versus just leaving it unprepared and trying to bond on top of it. So types of etching. Etching is very technique sensitive, and there are 3 different methods that we will typically use. So number 1, total etch. This is when both the enamel and the dentin are prepared at the same time. It does create high bond strengths, it is very technique sensitive, and it also can increase post-op sensitivity because you're applying a lot of etch to all parts of the tooth. Next, we have the selective etch method, which allows you to adequately etch the enamel without over-etching the dentin, because over-etching the dentin can result in increased post-op sensitivity, and it can also decrease the bond strength. So, for selective etch, we are first applying a layer of our normal etchant to the enamel surrounding the preparation. So as you can see in the picture here, it's just a thin line right where that tooth is going to meet the filling. And you'll leave this on for about 15 to 30 seconds. You'll then rinse and dry all of that etching off. And then next you're going to use your self-etch primer, so your etch primer bond all in one, like our Vivapen, on the dentin for 20 seconds. And that just gets dried, it doesn't get rinsed off, and then it gets cured as well. So this is just a method to help prevent sensitivity instead of kind of throwing all the acid on the dentin, which is that sensitive layer of the tooth. It still creates a very good bond because you're etching that enamel right where the filling is going to meet the tooth and have the most chances of any micro leakage getting in. So you're good there, and then also helps to minimize patient sensitivity. So next we have self-etch, which is going to etch and prime the tooth simultaneously. It does incorporate components of the smear layer instead of completely removing the smear layer, which leads to less post-op sensitivity. The only downside is it is less effective at preparing enamel surfaces and sclerotic dentin, which can result in lower bond strengths. So not the strongest, but helps patients minimize their sensitivity, which is very important. Just a side note, sclerotic dentin contains dentin tubules that have become completely obliterated by the either calcification or deposition of new dentin, which then forms a protective wall between itself and the regular dentin. So it's kind of like some unruly dentin that's there. It can be very hard to penetrate with the bonding agent, which can lead to ineffective bonding. And then this type of etching is available in either one-step or two-step systems as well. Next, we have primers, which are wetting agents that are compatible with moist dentin and bonding agents. They help to prepare the dentin to permit a better bond with the bonding agents, and they're typically placed on moist dentin and then partially air dried. You want to avoid desiccation, avoid completely obliterating the tooth dry as a bone, because that's not going to allow for the best bonding. And then a side note, some manufacturers have combined a primer with a bonding agent to permit both steps to be accomplished at the same time, called like a prime and bond. So going into bonding agents flow into the numerous micro undercuts and micro pores in the enamel and dentin made from etching. When composite is added, a chemical union occurs when the bonding agent and the tooth structure, which results in a strong bond between the tooth and the filling material. You do need to make sure that you're properly curing to provide good retention and sealing. Now, some bonding systems do combine the primer and bonding agent, like we just talked about, while others offer the prime and bond in separate bottles. Some systems even include the etch, primer, and bond all in one, like our VivaPen that we use during lab. Key note here, be careful to avoid excess bonding material from spreading beyond that etched surface, because it will not mechanically adhere to unetched enamel, which can then result in leakage, staining, and even recurrent decay, which we don't want. So how do we choose the right bonding agent? We can look at viscosity. If the material is too runny, it can create control issues and run all over the tooth, and then you just have bonding agent everywhere. But on the other hand, if it's too thick, it can be difficult to thin out and cure, and even difficult to reach the microscopic areas of the tooth in order to create that good bond. There are universal options that include the etch, prime, and bond all in one unit, like the VivaPen. This can save time and money by eliminating the need for extra products, but it is very technique sensitive and can result in less than ideal bonding. Post-op sensitivity. It is a big concern for both the patients and us as clinicians. So sensitivity is typically caused by microscopic voids or spaces in the tooth where adhesive was just not able to penetrate. This then causes fluid movement within the tubules of the teeth, and then you get sensitivity. So we want to make sure we're looking for an adhesive that is proven to reduce post-op sensitivity. And then, of course, testing and reviews. We want to make sure we're using well-reviewed products, and also look at cost as well. So maybe the cheapest stuff is not going to yield the best results, but we may not want to use the most expensive things on the market either. We have to kind of see where our office budget lies and what things that fit into our finances. Curing lights. So curing lights are handheld light emitting devices that light cure dental materials. They can increase the restoration temperature by 40 to 50 degrees Fahrenheit, which seems crazy, but I'm sure you've been around curing lights before. You can feel the heat that they do emit. So we do need to make sure that we kind of be careful using a curing light for prolonged amounts of time, especially when curing deeper cavities, because there is less dentin to dissipate that total heat energy, and it could lead to affecting the nerve of the tooth, which isn't great. Proper eye protection should be worn when using the curing light, just to prevent any eye injuries. Always read the manufacturer's instructions for not only proper disinfection protocols, but how long certain materials should be cured. Newer lights, actually, I've seen ones with just 2-second buttons that you only have to cure for 2 seconds. I don't know how much I trust that, but obviously it's proven to work if they have it on the model. So you would have to read that curing lights manufacturer's instructions to see what their recommended curing times are. And curing lights should also be tested just to make sure that they are emitting the proper amount of light and actually properly curing. So how do we properly use the curing light? We want to make sure we keep it parallel and centered to the surface being cured, because tilting the curing light can cause surrounding tooth structure to actually block the light from being delivered to the intended surface. Then it's not going to be properly cured, and it could lead to the filling failing, patient sensitivity, all things we don't want. Maintain your position while you're curing. If you happen to look away, because we're trying not to look at the light, our hand can actually drift and the restoration may not cure properly. We should always wait several seconds between curing cycles to help reduce that risk of overheating the pulpal tissues. And then also make sure you're following the manufacturer's instructions for the proper and recommended curing time. So some special considerations when working with composite. Composites should not be dispensed until they are ready to be used. Ambient daylight and operatory lighting can begin to harden materials prematurely, so you don't want to just have the overhead lights sitting or shining directly onto the filling that you're working on, because it can slowly start to cure it. Some new operatory lights do have a button that you can push to remove that blue light, and it almost shines a more yellowish light to help prevent premature setting. And then composite resins that are exposed to air while setting naturally develop an unset air inhibited layer. This unset layer helps to join that next layer of composite. So if you're placing more layers of composite, you cannot polish or finish in between and take that air inhibited layer off. It's needed to join that next layer. So if you accidentally place the filling, you end up polishing, and it's too shallow. There's not enough like anatomy, it's not an occlusion, something like that, and you need to add more composite. You can't just add another layer on top after you've polished. You now need to go back and start the etch, prime, bond, composite process, instead of, if you are placing a filling and are placing increments initially, as long as you don't finish and polish, you can just keep placing new layers without adding more bonding material. So there are two basic types of composite that we will see in the dental offices: flowable and packable. Flowable is obviously more viscous, it can flow into those empty spaces, while packable is closer to a Play-Doh consistency and needs to be pushed, condensed into empty spaces. There are some advantages and disadvantages for each type. So flowable composite, it is, again, very fluid, so it does allow it to kind of seep into different areas that a packable composite can't get to unless you really are packing it in there. So it's ideal for PRRs, preventative resin restorations, which are similar to sealants but just a little bit deeper, to help prevent any decay from forming into the grooves of back molars. Pit and fissure sealants, class 5 abractions, the first increment in the proximal box for a class 2 composite, for bonding ortho brackets on, and even sometimes minimally invasive class 3 composites as well. Let's talk a little bit more about the advantages and disadvantages of flowable. So, talked about this already. Flowable is very viscous. It can flow into any irregular spots that compactable composite may not be able to reach. It has the ability to form layers of minimal thickness, which helps to avoid voids, air bubbles in the filling. It is highly flexible, so when put into areas of high stress, where we're kind of really clenching, grinding, especially at the cervical areas, it flexes when we are chewing, biting, occluding on it, so it's not as likely to fracture or break. And there's also lots of different shades and colors available. Some disadvantages, though, it shrinks a lot when it's cured due to that lower filler load of the particle sizes. So when we cure it, it does shrink a little bit. And it also has weaker mechanical properties. Then we have packable composites. So for most restorations, you will be using packable composite, and a condenser of some sort is used to compact that composite into the preparation to help avoid voids, air bubbles, and to ensure that it is properly adapting to the preparation. Again, it also comes in a variety of shades, and some even for enamel shades and dentin shades. There's lots of options. Different brands will have a different consistency. Some feel heavier, others feel more pliable, so it just kind of depends the brand that your office works with. They do not shrink as much as flowable composites when cured, and they can come in a variety of ways. As you can see in the pictures on the side there, the top one is a composite gun dispenser, but on the bottom they also have twist dispenser options where you twist it up from the bottom and just take what you need. So many options with packable composite as well. So how do we choose the right composite? Talk with your doctor. A lot of the times dentists will have a specific way that they place fillings based on what they either have learned in school or just picked up over time while they are practicing as dentists. So the dentist that you work for will typically want you to place fillings the same way they do, just for consistency and as a quality measure. So make sure you talk to your dentist and simply ask them what products they prefer to use and would like you to use, especially when using flowable versus packable composite. They are usually more than willing to let you know and give you any tips or tricks that they typically use themselves that you can start to incorporate into your filling workflow. You can also ask other EFDAs in your office as well. They typically already know what the dentist likes to use, they know the products in your office, and they can give you insight on what works for them and what doesn't. And then also location. Flowable composites have lower filler volumes, and therefore they're just not as strong as packable composites. So just keep this in mind, especially when you're placing larger restorations that would benefit from the extra strength that the packable composite provides. Try to only use flowable in the box area of larger composites. You definitely don't want to fill up the whole preparation of a large restoration with flowable. It's just not going to turn out great. So shade selection, it is super important when we are working, especially in aesthetic areas like the front teeth. The Vita Classical Shade Guide is the most standard guide that is used in dentistry. There are 16 tabs arranged into 4 groups based on hue, and then organized within those 4 groups based on chroma. So hue is the type of color, so is it more yellowish or more reddish, and then chroma is the depth or saturation of the hue, which is the quality of the color's purity. So gray equals more neutral, where a bright yellow color is going to have a more high chroma. And then also there's value, which is the brightness, darkness, overall intensity of the hue. So black has a low value and white has a high value. Offices may not have every color composite that is available on the shade guide because usually a lot of the darker colors just aren't very popular. So a lot of the times offices will have all of the A shades and then a few other popular ones such as B1, which is like a very white shade. They're usually kept in stock. Some disadvantages of shade guides are that the color can differ from each manufacturing company, or even that not all colors are represented in the shade tabs, so we have to kind of match the closest one. So going more into shade selection, it's usually a good idea to determine the body shade of the tooth first, and then determine that cervical and incisal edge shades to ensure that there's a smooth transition between them all. As you can see in the picture there, usually teeth don't have just one shade from top to bottom. It's usually a little bit darker around that cervical third, a little bit later at the body, and then usually at that incisal edge it is lighter, even more translucent. So shades do vary from top to bottom. Shade tab should be positioned parallel to the tooth that's being matched, and then it also sometimes is helpful to add a black contrast behind the teeth that helps determine what colors are looking better. Let's go over some special considerations. Always start shade selection at the beginning of the appointment to avoid dehydrated teeth. The more the tooth is worked on and dried, the duller and less colorful the tooth will look like. So get those shades before the appointment, the preparation part of the appointment starts. Next, keep the patient eye level with you and use natural light if possible. Try to make your shade selection between 5 to 7 seconds because after that our eyes start to get fatigued and colors start blending together a little bit more. If you need to, just blink and look away for a few seconds and then look back again. And then last, remove any bright lipstick, or if a patient is wearing very bright clothes, try to cover those clothes with a patient napkin, or some other lighter colored article of clothing. You can always do a mock-up as well if you're unsure what shade will look best. So if you want to add a little bit of composite without bonding it, just to help see if the shade actually does match, you're more than welcome to do that, as long as it's easily removable. So we're not etching, we're not bonding, we're just placing the composite there, and then it should be able to pop right off. So be sure to check this video out in the materials and resources section of this week's folder. Next, we'll talk about placement of Class 1 and Class 5 composite restorations. So steps for placing a composite restoration. First, we want to make sure that we have proper moisture control. We're properly isolating before that restoration is starting. Next, we want to etch for 15 to 30 seconds, depending on what etchant method you are using. Next, we will prime and bond according to manufacturer's instructions. Steps 2 and 3 can also be combined if a universal etch, prime, and bond adhesive is being used. Next, we will add 2 millimeters of packable composite to the bottom of the cavity prep and pack towards the walls of the preparation. We will then cure. Then we'll continue adding composite in 2 millimeter increments to fill in the occlusal anatomy. And then step 6, check contours to ensure that the restoration is not under contoured. If it is, you can add more material at this time as long as you haven't started to polish it all yet. So be sure to watch this video in the materials and resources section. Same with this video, please watch it in your folder. Same with this one, keep watching them. So next we'll talk about a Class 5 composite. Very similar, a little bit different. So again, ensure proper isolation. You can place cord and hemostatic solution if necessary if the gums are bleeding there. It also helps to push the gums away a little bit for better visibility. So keep that in mind. Usually no matrix system is used though for a Class 5. You'll want to then etch for 15 to 30 seconds depending on what method you're using, and then prime, bond, and cure. If you are using a universal system, it has etch, prime, and bond all in one step. Then for a caries related Class 5, I'd recommend using packable composite in 2 millimeter increments, just because it's a little bit stronger. But for abrasion related Class 5s, you can use flowable composite. And then last, check contours to ensure that the restoration is not under contoured. If it is, you can add more material at this time. Please watch this video in the materials and resources folder. Same with this video, please watch it. And this one as well. Thank you.